I am Professor Sanjeewa Padumadasa of the Department of Obstetrics and Gynecology, University of Caesarean, Sri Lanka. Today, I will take you through umbilical cord prolapse, a serious emergency as far as a fetus is concerned. Although the perinatal morbidity and mortality due to cord prolapse have reduced over the years, still awareness about risk factors, anticipation, early diagnosis and prompt treatment are important for a successful outcome. Umbilical cord prolapse is defined as a descent of the umbilical cord through the cervix in the presence of ruptured membranes, either past the presenting part, in which case it is referred to as overt, or alongside the presenting part, in which case it is referred to as occult cord prolapse. In cord presentation, the umbilical cord lies below the presenting part but above the cervix. In cord presentation, the membranes are usually intact. What are the reasons for fetal hypoxia in cord prolapse? The loop of umbilical cord is compressed between the bony maternal pelvis and the presenting part, which leads to reduction in the blood supply to the fetus. In addition, the umbilical cord vessels exposed to the colder temperatures outside the vagina undergo spasm, which further reduces the blood supply to the fetus. What are the risk factors for cord prolapse? Cord prolapse can occur whenever there is space between the presenting part of the fetus and the bony maternal pelvis, leaving room for the umbilical cord to seep through. Such as in breech presentation or abnormal lies such as oblique, transverse lie, polyhydramnios, a low-lying placenta, and in the second of twin following the delivery of the first. Obstetric interventions such as external cephalic version, internal podalic version and breech extraction, artificial rupture of membranes in the presence of a high presenting part, and Foley catheter induction of labor are risk factors for umbilical cord prolapse. Cord prolapse may also occur in multiparous women, preterm labor, preterm pre-labor rupture of membranes, in the presence of a small fetus and fetal malformations. A vaginal examination, if at term, or a speculum examination if preterm, should be performed if membranes rupture, especially in women with risk factors for cord prolapse. A vaginal examination is mandatory if there are CTG abnormalities during labor, not only to assess the status and progress of labor, but also to exclude cord prolapse. It is good practice to exclude cord presentation before amniotomy in all women. Amniotomy should be avoided if the presenting part is high. If at all there is a need for amniotomy with the presenting part still high, it should be a stabilizing induction, which involves commencing an oxytocin infusion Performing amniotomy once uterine contractions are established, while an assistant stabilizes the presenting part over the pelvis, releasing lipo slowly, stabilizing the presenting part at the pelvis for some time, and maintaining uterine contractions with the oxytocin infusion. However, prostaglandin pessaries are a better option than amniotomy for induction of labor if the presenting part is high. Undue upward pressure, which can displace the presenting part upwards, should not be applied during vaginal examination. As the risk of cord prolapse is higher in a foot-link breech compared to in other types of breech, Caesarean delivery is recommended for viable foot-link breech presentations. In overt cord prolapse, loops of the umbilical cord can be seen outside the introitus or felt within the vagina, or visualized on speculum examination. Usually, the only indication of occult cord prolapse would be fetal heart rate abnormalities. Once a diagnosis of cord prolapse is made, prompt action is required to save the fetus. Although examining for cord pulsations is the most practical method of ascertaining fetal viability, it is unreliable because cord pulsations may be weak and therefore not felt even if the fetus is alive, and on the other hand, the operator's own pulsations may be felt even if the fetus is not alive. Similarly, a handheld Doppler fetal heart rate detector may not be sensitive to detect a weak heartbeat. Therefore, visualizing the heartbeat by abdominal ultrasound examination is the best method of confirming that the fetus is alive. If the fetus is dead or has a lethal abnormality, vaginal delivery should be aimed for. If the fetus is alive, delivery should be expedited. Usually, this would mean a category 1 caesarean delivery. However, if the cervix is fully dilated and the presenting part has sufficiently descended, an instrumental vaginal delivery can be performed, taking care to avoid impingement of the cord as much as possible. Until delivery, the principles of management are: 1. Relieve compression of the umbilical cord. 2. Relieve spasms of the umbilical cord vessels. What are the methods that can be used to relieve cord compression? These are: 1. Digital elevation of the presenting part. 2. Bladder filling. 3. Placing the woman in knee chest or exaggerated Sims position. These can be used in isolation or in combination according to the clinical circumstances. Let's take a few examples. Cord prolapse in the labor room. Multiparous woman having strong contractions. Cervix 5 cm dilated. Operating theatre next door and is immediately available. Digital elevation of the presenting part is the best method to relieve cord compression in this case until caesarean delivery is performed. The operator's index and middle fingers are inserted into the vagina, and with the tips of the fingers, the presenting part is elevated slightly. This should relieve the compression on the cord. One should not exert pressure on the cord when performing this maneuver. Similarly, one should not elevate the presenting part excessively. as this may cause more of the cord to prolapse. Let's take another example. Cord prolapse in the labor room. Multiparous woman having moderate contractions. Cervix 4 cm dilated. Operating theatre available only after 15 minutes. In this case, placing the woman in knee chest position is the most feasible method of relieving cord compression until cesarean delivery is performed. Now, let's move to another case. Rupture of membranes in a multiparous woman who has been admitted at 34 weeks because of unstable lie. Cord prolapse detected on speculum examination. Fetus in transverse lie. Operating theatre available only after 30 minutes. In this case, a combination of bladder filling and placing the woman in exaggerated Sims position, which is less tiring than the knee chest position, may be appropriate. In bladder filling, a urinary catheter is inserted. The bladder is filled with around 500 milliliters of normal saline and the catheter is clamped. The woman is then placed in exaggerated Sims position. The clamp should be released to empty the bladder just before entering the abdominal cavity at cesarean delivery in order to prevent bladder damage. What if cord prolapse occurs in the community? Again, the exaggerated Sims position is the ideal method during transfer to hospital. Now let's take a situation where the cord is outside the introitus, the woman is not in labor, the presenting part is high, and it would take about 3 hours until delivery. In this case, the prolapsed cord can be gently placed in the vagina. And a moist gauze inserted below it. In order to prevent the cord vessels from going into spasm. But excessive handling of the cord, which might aggravate the vasospasm, should be avoided. Cord prolapse in a primigravida undergoing induction of labor. The cervix is 6 cm dilated. All emergency theatres occupied at least for a further 30 minutes. Digital elevation of presenting part utilized. Despite discontinuing the oxytocin infusion, she is getting strong uterine contractions. There is fetal bradycardia. What would you do? In this case, acute tocolytics, example, 0.25 mg of subcutaneous terbutaline has a place. Once the baby is delivered, the umbilical cord is clamped immediately and the baby is handed over to the neonatal team for resuscitation. In summary, it is important that one is aware of the risk factors for cord prolapse. The various methods to relieve cord compression, that is, digital elevation of the presenting part, bladder filling, placing the woman in either knee chest or exaggerated Sims position, or gentle placement of the cord inside the vagina, can be utilized until delivery, depending on the clinical circumstances. For a detailed description on the management of cord prolapse and other obstetric emergencies, please refer the book Obstetric Emergencies, a Practical Manual, the link of which is shown in the description below. I hope you found this video on umbilical cord prolapse useful. Thank you.